Yeah, okay. I'm going to say, what we were thinking a few words before it starts, just to tell everyone what's going on. So yeah, there's everyone comfortable. Okay. Cool. Dave. Sorry. I'll say that before you let us speak. Okay, so can I say it? Yeah, people online. Yeah, okay. Right, should we make a start? Okay, I'm just waiting for people to come in. I've been asked a few things, really. The first thing is, you know the people in the back row, would you be kind enough to move forward? You don't have to move forward now, but when we serve lunch, apparently we've got some very senior, distinguished world leaders coming here today, and they've hijacked where we were going to have catering. So we will have to have catering in here. But we're nurses, and other people, we can cope with that. But we need to serve it on the back row. So that's number one, and that's really important because I know you'll all want lunch by the time we get there. The second thing is, this is Dave Monday, who I'm sure many of you know, and Dave has kindly offered to live stream the event because so many people wanted to come, but so many people couldn't come because of work and everything else that's going on. So first of all, does anybody object to this being live and sharing it with our colleagues? No, okay, good. The second thing is, bearing that in mind, so bearing in mind this is going out on live streaming and people will be sending tweets and all the rest of it, we need to be very mindful of what we say. And that's not to say, you've got to say what you think and you feel. And I know how passionate people are about this, where we are at the moment. But it's a bit like if we can try and not to name organisations or trusts or drop anyone in it, that would be really helpful, I guess. Okay, so I know you will because I know most of you and I respect most of you, and I know that you will treat people with respect and dignity. Okay, so why are we all here? Well, I guess we all saw the programme, the latest scandal. We're all upset by it, and from what I saw, people feel very passionate about it, and really want to do something about it, but didn't really know what we could do. So I just said, why don't we get together and start the conversation? Because I don't know what is happening. In preparation for today, I think I've spoken to about 50 people from, various organisations, from the NHS, from the Department of Health, from NHS England, from NHSI, from Health Education England, to try and get a feel of what is it, what are we trying to do, and what can we do mainly as learning disability nurses who probably, apart from people with learning disabilities and their care, who probably know more about this area and want to actually improve things as they are. So anyway, they were all very supportive of having a day together, and they're all very interested in getting whatever feedback they can get in order to get things improved, I guess, and to try as best we can not to let another situation like Walton Hall happen again, really. So in addition to speaking to people and thinking about, okay, so we'll get people together and then what? The other thing I did was read up again on every policy, document, strategy, whatever, that has been issued in the last few years. And I have to say, when I read the documents, I think, yes, this all makes sense. Yes, this is what should be happening. But basically, what is going wrong that is not happening? What is happening, I mean, mainly in the NHS, but also in all the other sectors as well, that we can't, that things like Walton Hall happen, and that not only is it neglect and poor care, but it's abuse. So it's like, why? And we've talked about culture. It must be, there's something going on. We know there are power struggles. So we've looked at all of that. I mean, I've looked at all of that with many of you in this room to think about what we can do about that. So what we planned for today, first of all, how lovely to see you all. And I'm so glad you came. But we thought we'd have a presentation from Dave, just to get us in the frame of mind, about the standards of care that now should be implemented everywhere. And then we thought we'd break into pairs and then do a bit of exercising to try and get people to come up with ideas and everything. And then we'll come back, have a discussion, have some feedback, decide where we want to go with it all. And then David Harling couldn't come today, but he has prepared something for us that he's been thinking about working at NHS England. And Ben is here, Ben Briggs is here, and Ben and Dave will do that presentation to sort of more or less finish off where we are, to see, I think, if the stuff that we come up with is in line with what's come up from the centre, really. And I'm not a big centralist. I think, the centre can do marvellous things, but at the end of the day, it's the people who look after people with learning disabilities that are going to make the difference. And unless they're on board with everything, then we're just thrashing around, I guess. So Dave, would you come up and give us your presentation to kick us off? Is everybody all right? And don't feel you can't say anything, question us. It's got to be a discussion. Eddie?
Ben, I just wondered if we could a Twitter hashtag or anything for people on the live stream, so we can collect their comments as well.
Dave, you got it, haven't you? LDN Action?
Sorry?
The Twitter thing?
Yeah,
the hashtag, yeah.
Yeah, LDN Action.
Yeah. Okay. Hello. Okay, right, Dave, thank you.
Hello everyone, lots of friends. I'm really only going to talk for about 15-20 minutes about some of the stuff that I've been working on with NHS Improvement around standards, because I guess we've got an issue with standards. And I was involved in putting that document together. Documents are easy, and I've written loads of documents that don't necessarily make something about kind of collectively how do we pick things up and use them to make a difference. Just by, I guess, in terms of framing the day, it seems a useful place to start. So, document on your left, so that was the standards document that was published last June. So I'm going to talk a little bit about what it is, how we developed it, what we've done with it since, and then I guess really the rest of the day is about a discussion about how do we make standards real for people that are using services. Okie doke. So why did we develop them? And I think the themes in red are the things that everyone's familiar with. Too many variations in terms of the outcomes that people experience that are unwarranted, unjustifiable. It's readily apparent when we look at reports and scandals and safeguarding, serious case reviews and so on, that people's care and treatment isn't always safe and it's not always personalised. Many of the kind of failings that we look at, whether that's about people dying too soon, whether that's about people being abused, whether it's about restrictive interventions, I guess many of these things can be kind of backtracked to kind of human rights issues. And there's something within kind of human rights movements about the indivisibility of human rights. So they're all of equal significance. We can't pick and choose which ones we honour. The moment we start doing that, we detract from the whole thing. Concerns about skills deficits. We know that learning disability nursing is challenged in many areas at the moment in terms of numbers. And I guess above all, just we know that people with learning disabilities aren't getting the same outcomes that other people would expect. So in essence, that's why we thought that we needed standards, and you'll notice that at the top it says standards for NHS trusts, and we'll kind of come on to that a little bit later in terms of what's the implications for other sectors. So the aims, in terms of putting this document together, I guess what we hoped was that if we get it right, and if these standards, it's not about writing a document, if these standards are truly embedded into the way that services are organised and delivered and the systems and structures that we use to deliver the outcomes that people want, we should see improvements in the quality of support, we should improve coordination and integration of different sectors, we should be able to reduce some of those variations in terms of the kind of inequity of outcome that we see too often. We should be able to improve people's satisfaction with the services that they receive, and overall planning should improve. Sure. So I guess two big things that influenced my thinking and colleagues when we were putting this together. So first of all, a lot of kind of human rights based thinking. So we were fortunate to get lots of help, support, advice from British Institute of Human Rights, and I've done bits and pieces before that have looked at human rights based approaches to care and support. And I guess so the kind of key sort of tenets that run through that are around European Convention on Human Rights and the Human Rights Act. And in particular certain articles, so those articles that relate to people's right to life, people's right to freedom from cruelty, inhumane, degrading treatment, people's right to liberty, to family life, and to be free of discrimination. And we know that those articles are the ones that often crop up when things go wrong in services. Of course, the Equality Act is significant to us, the UN Convention on the Rights of People with Disabilities, the mental capacity legislation, and equivalents in other UK jurisdictions, and the same with mental health legislation. So we know that we have to kind of pay close attention to those. What we wanted to do is make sure if we get the standards right, that they kind of draw services to a better place, hence the picture of the guiding star there. So the other thing that influenced us, the other thing that influenced us was thinking about kind of what does good person-centred care look like, and there's almost no point going on. We ask people with learning disabilities and we ask families this repeatedly, and pretty much we consistently get the same answers. It's not radically about to change, and lots of user-led organisations were very clear with us from the outset on that. So what do people want? People want to have fair access to services, they want reliability, they want to know that they're going to get a similar level of service wherever they go. They believe that treatment should be effective, so we should have some evidence base that tells us what we're doing with people is likely to have some positive impact. There should be good continuity around care and transitions, and that's transitions everywhere in service land where we've constructed fracture lines, health, social care, NHS independent, that all of those points of transition should be smoothed out. People should be involved in their own decision making, and there should be respect for people's choices. It's the stuff that people have been telling us certainly for all of my career. We should have good information for people. We should promote and support people's self-care, full involvement of families. We should understand that for people who use services, whether that health services but also social care services, that can be quite distressing, so there needs to be good emotional support. We need to recognise the need for respect and empathy within that, and we need to think about the environments within which we deliver care and support to people. So these are the kind of golden print, and this is Picker Institute stuff, but these are the things that every time you look at person-centred care and what defines good, it's going to come up with a similar list. So we had that, and we had human rights running alongside as we were putting these things together. So in terms of how did we develop them, we worked with, well, I guess our starting point was working with lots of self-advocates. And you see how they've all got the green cards up there. That was very much staged. In reality, when I was talking to them, there were red cards every 2 minutes, I'm afraid. I'll come clean with you. I think that's colleagues from Pathways. Some people from the Northwest will know Pathways Associates. So what did we do? In putting these together, the first thing was there was a very initial early preliminary draft, and that was put together on the basis of kind of site visits and conversations with people in services and people that use services. We then started to have lots of more formal conversations, and we started talking with people with learning disabilities and their families. And I guess some of the groups that were really, really helpful, Inclusion, and this is because I'm based in the North, I guess, so Inclusion North, Changing Our Lives down in the Midlands were really helpful and kept my focus where it should be, I guess, as I was doing this. Pathways Associates, and it was quite humbling. We reached out to a small number of families of parents who'd lost loved ones in services, who were able to talk to us about what they expected to see from services, which is quite humbling. We kind of thought about, so if we have a batch of standards, if those standards are truly going to be met, what does that look like when people use services? So self-advocates and families helped us to define those. We then went back and thought about the standards and what we've called improvement measures. So what are the levers? What are the things around system and structure? Because we know about system and structure in services, but how do we lever and manipulate system and structures to deliver the outcomes that people want rather than the outcomes that we want? And there was some really clear conversation about the fact that everyone has different outcomes of interest. So for any of us that use any kind of service, if I fall and end up having a hip replacement, the surgeon has an outcome of interest, which is about shiny bits of titanium and minimal scarring. The finance director of the trust has an outcome of interest, which is about cost. And I, as a patient, have an outcome of interest, which is about, I've got a really important family wedding to go to in 6. So we kind of recognise that the way we put these things together, we have to have an honest conversation that we all have different outcomes of interest, but then we have to ensure that the outcomes of interest, people who use services, have primacy over everything else. So that was kind of some of the thinking that developed as we were working on this. So then we kind of did the rounds. We went to trusts, we spoke at lots of conferences, we met with practitioners, we met with more self-advocates groups, lots of discussion with kind of system partners, academics, CQC, public health, pretty much anyone that would talk to us, and kind of refined until eventually we got the standards and improvement measures where we wanted them. And then we thought, so what we need to make that work is some metrics. We need things that focus people on moving towards this kind of desired place that people and families have defined. So we set about putting together metrics, ways that the organisations could understand where they are. So, how the whole thing hangs together. So we have a set of standards, some of which apply to all services, so every NHS service in the land, and some of which apply only to services that are solely commissioned for people with a learning disability. So, and the standards are really common sense, they're not rocket science. We've got one standard, the first one about human rights is basically saying that trusts should make sure people's human rights are respected. Well, they have to do that without me writing the document because we've got the Human Rights Act. But we wrote a standard around that. There's nothing controversial there. The second standard is around inclusion, and basically we're saying that all trusts need to make sure that people are involved in decisions about their care and their families. Third standard is around staff, and again, pretty straightforward. We're saying that trusts who are supporting people need to have the right skills. So again, fairly straightforward. And for specialist services, we've said that trusts who have services just for people with a learning disability need to make sure that they, again, have the kind of levers in place to deliver what national policy is saying that we should. So the standards in themselves are pretty high-level statements. Sat underneath those, however, we've then got improvement measures. So these are kind of slightly more definitive statements about how we would expect those things to manifest. And these are the things that were tested out in conversation with people and families. So here's our improvement measures. I'm not going to go through them all, but if we look at human rights, we say that trust should be making reasonable adjustments. And then we've got metrics, which we'll come on to, which is where we hope that services can demonstrate that they make reasonable adjustments. They should have flagging mechanisms. People with learning disabilities should be visible within the data systems so that we can understand how people are progressing and how people are faring within services. We should learn from when people die within our services. We should have measures to protect people's liberty and people's freedom. And we should be able to look at and demonstrate that we're not delivering services in a discriminatory way. So a series of improvement measures that sit underneath each of those main standards. Okay. So underneath that, we then, as a result of the conversations that we'd had with people and families, started thinking about metrics and how will we know when these things are happening. So people with learning disabilities and their families described the outcomes that they would expect if those standards are genuinely being delivered. So then we were able to start thinking about, so who knows what when it comes to healthcare? Who knows about structure? And who knows about systems? And it occurred to us that managers know loads about structure. Managers know what the budgets are, how many beds they've got, when the policies were last reviewed, what the training compliance. Managers know structure. In terms of how is someone supported when they walk through the doors of a department, we think that frontline staff have a better grasp of that. So we came up with two sets of metrics or questions. So one for staff, which kind of target process and systems of support, and a set of questions for trust managers that largely relate to structures. So we might ask managers, do you have up-to-date policies that reflect ABC? And then we ask staff about their ability to work with those policies and to deliver those policies. So as a result of that, we came up with loads of metrics. Don't look at all the numbers. Basically, we came up with bloody hundreds of the damn things. So we ended up, people and families, I'm not even going to add the numbers. For managers, though, we ended up with something like 105 potential questions that we could ask managers about the structure of services, and again, over 100 questions for staff about the actual process and systems by which people are supported. One of the things, I guess, since working on this, one of the things that's really influenced me is some of the work that's been done previously by the Vanguard method consulting people, and some of the stuff that they've written about culture, which is, I guess, something that will crop up today. And some of the thinking that I've taken on board recently is that often culture is a result of systems and structure. And if we don't change the systems and structure, culture will revert back to the defaults. So actually we probably need to look at system and structure, and that hopefully will then guide culture to a better place. And there's a lot of kind of thinking about that. Anyway. Okay, so what have we done with this stuff? So some people will be aware that the NHS Benchmarking Network were commissioned to undertake a survey. So we essentially gave them a subset of those metrics, some for managers, some for staff, and some outcome questions for people and families. And we asked them to go away and do a survey. And it's yielded some really useful data. It's not perfect. I think we've learned, so the reports are due out imminently. I got a text last week saying it's going to be in the next few weeks. In terms of the methodology, we've got some good data. There are some areas that in future we'd probably like to drill down into more detail. And I think there's some areas of the methodology, particularly around how we get information from people that use services and families that we want to work on a bit further. So we know there's some other areas that we're going to look at. But I've seen the raw data and there is some really useful stuff in there. Some of the sorts of things that we're picking up, and you can kind of read these two ways. So nearly everyone, people with learning disabilities that were surveyed, were saying that they were treated with respect, which is great, but it wasn't everyone. It was nearly everyone. So if you're one of the ones that it wasn't, then there's a problem. Most people, again, same problem, said that they received high quality care. 3/4 of people said that staff explained them to a way that they can, which is great, but if you're in the 25% where no one told you, we've got an issue. And it's back to that theme of disparity, which is the reason that we developed the standards. And I guess what we've done with the survey is to measure to some extent the extent of those disparities. 7 out of 10 people said that staff had enough time to talk with staff. Again, great, but not so good if you're one of the 3 in 10 where that didn't happen. 2 out of 3 staff said that staff talked to them about their rights. Fantastic, but what about the other third? And again, this is, and I guess some of what I've done in terms of interrogating that raw data, it's the same all over the country. It's not massive regional variations. So consistently we have disparities. Other things, and this is a crucial one, 8 out of 10 people told us, trusts told us that computer records show if a person has, so basically has effective flagging mechanisms. So we've got 20% of trusts who really can't monitor. If you can't flag people, it gets really hard to do lots of other things, to pick out different patterns of mortality, of morbidity, to pick out whether you've got disproportionate numbers of complaints concerning people. It gets, unless people are visible within the system, we've got a real issue. And 20% of trusts are saying that they really struggle to do that. It's clear that some trusts are doing really well in terms of information systems, but for others, records are just rendering people invisible. Interesting, this kind of resonates with my experience. As an aside, we asked people with learning disabilities how many people have got a health passport. Around about 60% said that they had. Whenever I ask groups of self-advocates for a show of hands, that's roughly, almost predictably, the figure that comes up. But then we found out that only 6 out of 10 people said that staff were reading their health passports. So what's the point of filling them in? There are other bits and pieces when the report comes out, and there's also some of this data is going to be put together into an accessible information standard report that CQC are going to publish shortly. Some really interesting snippets. We got some buy-in from smaller organisations who we didn't expect to fully engage with this benchmarking exercise. So a couple of ambulance services engaged, and actually there's some really, to me, I don't know much about ambulance services, but real positive stories. So there is some good bits and pieces in there as well, which has led us to think how we might do things differently next year. What else have we found? We trusts get disproportionately more complaints about the care and treatment of people with learning disabilities than other people. And by the time the report's published, we'll kind of quantify that as best we can. But it is disproportionate. We also found lots of people who with learning disabilities who said that they wanted to make a complaint, who told us that they'd wanted to make a complaint at some point when they've used services for, they don't tell us the reasons, but ultimately decided that they didn't want to. 1 out of 4 staff told us that no one checked if they've got an advocate, which is kind of worrying. So kind of mixed bag of things, and there's loads more when the report comes out. So that's one. So we've done that benchmarking survey. It gives us a kind of state of the nation overview of the extent of those disparities. We've got the improvement measures, we've got the metrics, and what we hope is that it's not just about us looking in or asking the benchmarking network to do that and to say, aren't things awful? There's got to be something about helping things to get better. So we've had an attempt to do this, and hopefully it will help. So we've developed an improvement toolkit. This is purely focused on avoidable deaths of people with learning disabilities, predominantly adults, in the way it's framed at the moment, in acute hospital settings. So we picked out one area of concern from all of that benchmarking and thought, have we got some stuff here that whereby organisations can self-improve? So we've developed this. It's an improvement toolkit. It's essentially a fancy Excel spreadsheet, although it's designed not to look like that because for some reason some people don't seem to like spreadsheets. I love them, but there you go. So it should just look like a normal piece of software. You'll see up at the top we've got questions for managers, questions for staff, an improvement summary, so it kind of summarises the position of an organisation, and then starts to generate an action plan. So this is going to be launched at the same point that the reports from the benchmarking network, the survey, come out. And the aim is, when we piloted this in 4 areas across the country, we kind of run a couple of workshops. So a 2-hour workshop for a cross-section of managers from an acute hospitals trust, and then a similar 2-hour workshop for a cross-section of frontline staff. Again, we're asking managers about structure, we're asking frontline staff about systems, about actual care and support. So within that, people work through a whole series of questions. It's designed to be projected up on screen, so it's full of macros, so whatever question you're talking about automatically turns yellow. So you know when you sat at the back of the room and you're not quite sure what people are referring to. We've got a series of rating scales, so we ask people, so for instance, let's read out the yellow one, but in total there's 30 odd questions for each, but we ask, so what's this? This is around respecting and protecting people's right. The improvement measure is that trusts should have measures in place to promote anti-discriminatory practice. And so we asked people, does your trust monitor numbers of patients with learning disabilities on waiting lists and the lengths of their waits so that comparisons can be made with other groups, and if there are concerns, they're proactively reported to commissioners. We then have a little basic what it means box, which is essentially, are you checking that patients with learning disabilities don't have lengthier waits for services and and that's what we're getting at. So we asked a group of managers to sit in a facilitated workshop and answer a series of around 35 questions. We then repeat the exercise with frontline staff. So here, for instance, the top one is, as far as you know, does your trust use systems and measures to check whether the experience of patients with learning disabilities who use your services are the same as everyone else's? So pretty simple question, straightforward, and this is focused on frontline staff. And our what it means says essentially good governance arrangements should mean that teams get to see and reflect on how they're doing. So we have a whole series of statements, then we graph them up, so we get an overall graph. So as I say, this is acute hospitals focused on avoidable deaths. I suspect within all those hundreds of metrics I talked about, I think we need to go back to those and look at the wealth of information we've got in there that we generated with professionals, with practitioners and with people and families, and see if we've got the makings of more self-improvement toolkits. So having done those workshops, we graph it up. So for an acute trust, we'd be looking at how people are performing against each of the 3 critical standards that apply to acute hospital trusts. Everything's RAG rated. And essentially this is combining what we've been told by managers and what staff have told us. We then compare and look at where there are discrepancies. So typically when we ran this for real during piloting, we found that on the whole managers are about 10 to 15% more optimistic about their services than staff are. And that's fine. So you kind of get used to that and you can work perhaps within that 15% tolerance level. But when you get that column on your right, workforce, we've got something that needs looking at, where managers are so out of sync with the way that frontline staff are reporting service delivery to be, then we know that in terms of improvement action, this is something we need to go and explore. We then have a more sort of standard traditional dashboard. We look at the optimism that managers have expressed in terms of how quickly they think they can deliver against each of the metrics that combine to form these standards and improvement measures. But then we moderate that with the pessimism that's sometimes expressed by frontline staff. So we get an overall dashboard that allows us to make some predictions about how quickly improvement measures can be achieved. And this has been piloted in 4 areas, and I have to say each of the areas that piloted it, last time I spoke with them, they're all still working to this and they're still using it, so they found it helpful. We then look at of all the metrics that are described and the questions that are answered both by frontline staff and by managers, how many of those metrics are going to need an awful lot of bloody action to get it right, a bit of action, some action, or no action. And this was suggested by trusts to be helpful in terms of understanding how much work is going to be needed to achieve these things. We have some improvement trajectories, and we do that for each of the standards. So we start off by looking at where people think they are now, and on the basis again of managers' optimism, how quickly things might improve over the next 12-month period. And then finally, this took a bit of doing, there's a little algorithm in the back of this thing that for each of those metrics works out potential areas of focus. It's then rating for each of those and there's loads of them, for each of those potential actions, which it calculates like an impact score. So in relation to areas where you're doing rubbish, if you do that, that's really going to help you. But actually it also impacts on several other areas. So it kind of calculates the top 5 areas where potentially an organisation should be looking to start in terms of improvement action planning. That took ages. Action planning template, this isn't the most rigorous thing that I've ever sort of sat down and looked at, but what we know is all organisations have got their own kind of governance and improvement action planning systems. So this is something to start a conversation. So we do our workshops, managers, frontline staff, we feed back some of those graphs to a mixed group of some of each, and then we have some preliminary conversations about improvement action planning that we know trusts will then transfer to their own systems. So you've got each of the improvement measures on the left. We have 2 things. So we talk about an improvement plan where things need to get better, Actually, if trusts are doing really well, that's fantastic, but you need to be able to sustain it. So we also have what we've referred to as sustainability plans. And we were mindful of this when we were working particularly with acute liaison nurses, where in some instances, one fantastic acute liaison nurse had such a massive impact across a whole hospital sometimes. But then you become really aware that they also become a single point of failure. Anything happens. So you've got to have that kind of sustainability planning. So we built that in, and essentially what needs to happen is a kind of pretty bog standard. On a really nerdy level, I'm guessing lots of people will be familiar with care and treatment reviews and the NHS England template for that, which has driven me mad for years because you can't spell check on it. So I wrote a little macro up there, so on mine you can spell check things. Yeah. And I didn't do that in NHS improvement time. That was a nerdy weekend that I spent working on that. Whatever floats my boat then. Okay, so what next? Let's not do it one at a time. So that's what we've done today. We clearly have more to do. These standards aren't going to change the world, but if people own them and if nurses want to have a part of it and can help us, maybe we can make them meaningful. So what are we going to do? We're already looking at kind of refining and updating the metrics. We've met with practitioners, we've met with people and families, and we're kind of working through how we need to refine some of those metrics. We'd like to start thinking about how we extend them to other populations. They need to be better framed around children and young people and to reflect some of the different kind of legal and service context around that. People who are involved in prisoner healthcare have been talking to us. Can we use these metrics to describe what good experiences of prison healthcare should look like? And the ambulance trusts are really keen to get involved. We're keen that there should be more benchmarking. In some instances we want to look at different stuff because new areas for focus and scrutiny come up, but also we want to build up a bit of a time series, so we also need to revisit some of the themes we've looked at before. And we know there's issues about data burden in terms of where this comes from, so we have to be mindful of that. We're keen to look at how these reflect CQC's key lines of inquiries and what the kind of crossover there is. There's something about us kind of picking out exemplars and using this benchmarking data to recognise where unusual things are going on, and not to make whether that's unusual things of concern or whether that's unusual things that seem astoundingly good, but where we see unusual things, let's go and have a look at them. Let's go and see what we can learn from it. That's my phone at the back of the room. Apologies for my awful tone. So we kind of need to, but we'd like others to be involved in that. So for instance, on the back of the piloting that we did when we developed the improvement toolkit, we've already got pilot sites on radically opposite sides of the country where acute liaison nurses are going to do peer reviews of each other's services, and we're going to facilitate that. What else? So a couple of real big things to do. So because there's reference to this, and these are now kind of recognised within the NHS long-term plan as being applicable to all NHS commissioned care, then it stops just being about NHS trusts. It starts to give us the ability to get these into other sectors. So that gives us a route into the independent sector, voluntary sector. It also gives us a real key link, because for us to embed these things and make these things meaningful in NHS commissioned services means working with commissioners. So there's something about how do you commission for standards, which is a question, a whole question I guess in itself. So it opens the door to that, which is important. And then the other thing, so that the improvement toolkit that we've developed so far, and I know it's not been launched yet, but we've had really good feedback from pilot sites. And I've worked on lots of stuff that I've been quite pleased with, but I'm really pleased with that one. But whenever Dave Harling said, I'm still new to the I'm revisiting the bureaucratic processes by which things are released. But I got a text last week and it should be like 2-3 weeks. But other improvement toolkits, when we developed those metrics, we had lots of conversations with lots of people and developed a really useful raft of stuff. And I think we need to go back and revisit that and look at other applications that we can put it to in terms of other improvement toolkits. It's too rich a resource not to revisit. And I think that's my last slide. Yes, that's my last slide. So I guess what I'm saying, me sitting and writing a document about standards doesn't necessarily change anything. We've had lots of, we've got legislation that's got standards in it. if it's a useful framework, and there's some evidence that it is, and yes, it's not perfect, and we'll refine it and improve it as time goes on in conjunction with people. But if it's a useful framework, and the standards themselves really can't be disputed, how do we make that real? How do we make that a thing that nurses do, and a thing that people who are interested in the structure of services commission for, and how do we make that the lived experience of people that use services? So that's me. That do?
Do an exercise shortly, but is there anything, any feedback? What do people think? Have you been involved in the standards?
Can I ask a question?
You
It
can.
might be a daft one, sorry if it is. When you said the standards are used like as a group in a workshop of managers
Yeah.
or a group of staff in a workshop,
Yeah.
is it a collective discussion that
Yes.
informs the answers?
Yes. So it's a facilitated. Just
Concern, does it feel like comfortable saying it amongst the group?
hasn't happened so far because it's acute hospital. I think there's almost a different culture. So the way that we've developed it in the pilot methodology is that myself and Ben and others have essentially facilitated group discussions. So I guess we've relied on our facilitation abilities. In the manual that will come out alongside the toolkit, what we're suggesting is kind of governance leads from neighbouring trusts and kind of impartial facilitators. And we've sort of described the skills and competencies that facilitators might need. But in terms of managers, I guess for that workshop, the experience was that it tends to be ward managers, deputy ward managers, senior medics, clinical leads. That's the kind of range of people that we got. In terms of frontline staff, very mixed. So student nurses, support workers, frontline nurses, AHPs. Essentially, I think it's down to the skills of the facilitator to draw out where there's disagreement.
I was thinking, for example, there might be some managers who don't want to show
Yeah.
to other managers
Yeah.
their
Yeah.
areas
Yeah.
where they think they're not doing so well.
Yeah.
So they might then give a heightened score.
Yeah. 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 Well, and the thing, it's a self-improvement toolkit. If people want to cheat, they might as well not use it. Do you know that you've kind of got to be on the starting blocks, I guess, if you're going to use it. As a self-improvement, so it's not a thing that we would be dictating that people should use. If you're motivated and eager to use it. Of course, we have lots of conversations with user-led organisations and families, many of whom will be, I gather, quite keen to go and talk with directors of nursing and acute hospital trusts and say, have you thought about using this? And some of whom I think will be quite keen to help with some of the facilitation of those.
Yes, I just wanted to ask around the transitions in care. Obviously, I was going to see
Yeah.
all the improvements,
Yeah.
and also for out of area.
Yeah.
Are those going to be encapsulated within those improvements?
So some of the metrics at the moment, the improvement toolkit is purely about kids, so that's not relevant to that. But within the wider set of metrics, there are metrics that capture transition issues. But the metrics are very much framed at adults at the moment, and we're aware of that. One of the things I'd like to have a look at over the next year is how we convert some of those metrics to start to get meaningful information from children and young people's services. Because you've kind of got to tackle the transition at both sides. So I think there's more work to be done there. There's other, autism. These are learning disabilities and autism. I'm not absolutely convinced that these metrics capture the experiences and hopes of people with autism who don't have a learning disability. I think we need to do some more work to validate that. So I think it kind of does what's at the core of the standards, but there are bits where we need to build on it.
Yeah, it's just a question from Twitter. How do we make these standards a reality? What can we, as LD nurses, do to drive change?
That's my question today. I can sit and write documents, but that doesn't necessarily change anything. What can I do? I mean, I guess what I can, so I do lots of things when I'm not working for NHS Improvement. I chair care and treatment reviews, I do bits of consultancy, and I guess that these are running throughout my head in everything that I do. But my head's full of them. I wrote a lot of them.
I think the answer will be clearer by the end of
Yeah.
today. Could that person wait?
And if these are not helpful, if these are not helpful, if these are not believed to be helpful, then we need to know.
I think they are helpful,
Mhm.
but obviously these are for acute trust.
Yeah.
Working in a mental health trust where we've got quite a number of people
Yeah.
with learning
Yeah.
disability, often going out of improvement standards within mental health or within
Absolutely.
disability
Yeah.
sections as
Well, the metrics, of course, span everything, but the improvement, that's the first. I would like to see that as the first of a suite of improvement toolkits. And I guess, we focused on avoidable deaths in acute hospitals because of LEADER. And I think now it's time to look at other areas.
And we've also kind of looked at those standards with people in that
Yeah.
data, and that's been really informative
Yeah.
to know where we need to make improvements.
Yeah.
And I think that's been a really useful exercise to do. But these are for NHS trusts.
At the moment.
At
But the
moment.
long-term plan gives us permission to extend them into anything that's NHS commissioned. But my issue there is working with commissioners. Like in the past we used to talk about commissioning for outcomes, and no one kind of ever really got their head around. But it's a bit similar. This is about commissioning for standards. And so I think we collectively need to have some conversations with commissioners about what that means and what that might look like.
Absolutely do. And we need to have conversations with CQC as well.
Yeah.
Because if we're using these
Yeah.
and building these into,
Yeah.
because it's all very well having the standards, but they need to be monitored
Yeah.
right
Yeah.
across
Yeah.
the system in order to impact
Yeah.
real change.
And I guess what I'm keen is to get that balance. There's got to be some monitoring, there's got to be someone looking from the outside in, but also that kind of support for self-improvement, because there are lots of people that want to make things better. And for some enthusiasts, one of the messages I get is that some nurses, some practitioners have used these standards within their own organisations to advance fights that they've been having with exec teams for years, and yeah, absolutely, which is what I would hope people would use them for.
Yeah,
You had your hand
from the questions just now. With the data that you've got so
Yeah.
far, you mentioned that it's fairly equal in the different regions
Yeah.
in terms of the feedback you get in. But do you have data on how things are getting on in the different regions? And I asked as a patient, not one local
Yeah.
mental health trust, it'd be really useful to know what's happening in that area.
So we haven't specifically cut it in that way yet. What we've looked at is a kind of state of the nation overview, I guess.
Okay, are there other places to get kind of trust by trust?
So all trusts have their own data.
Okay.
Yeah.
Okay.
Dave, CQC didn't pick up what these standards would do.
These are not a framework for inspection. They're not a framework for investigation. So in themselves, no. But I guess were services working to and delivering against these standards, it wouldn't happen. What I hope is if we say we're going to measure the service quality on any parameter, we know that services will twist and contort to look good, because in a kind of business continuity model, you've got to do that. Early on when I used to present this stuff, I used to talk, if we came up with the most abstracted measure of quality and we said that services where staff have got the largest average shoe size are the best, we'd rig it. We've all been there. We'd have job descriptions that look fine for equal ops, but we'd be eyeing up people's feet as they're coming through the door. And organisations would rig it. And so we'd end up with a workforce of people with massive feet, and we'd get all manner of unintended consequences, and we'd play games. And we can't stop that. I think what we can, if we make the guiding star, the shiny thing, the big feet, into something that actually has some validity, so that organisations have to twist and construct to actually get to a better place. And that better place hasn't been defined by us, but has been defined by people and families. Then I think we lever people towards a better place. But beyond that, there are other things that are needed.
I just wonder, because there's a greater sort of self-assessment element to it, that might provide a sort of forum for staff members who are uncomfortable with what's the status quo,
Yeah.
to give them a sort of a voice.
It's a thought. I suppose so what do they mean if you're a support worker who's been in post for 3 months? What does that actually look like when you go to work? Maybe there's something that could be done there, yeah?
Sorry, I want to ask something about the balance between, you mentioned obviously human rights.
Yeah.
And everyone has basic human rights.
Yeah.
And when an incident, say obviously something smaller than you should have walked home.
Yeah.
But if say in a working situation, there's a situation where a staff member has, is not acting as they should, and a manager is trying to deal with it. obviously that staff member has rights.
Yeah.
And what I'm struggling with is you know is trying to sort of emphasise the balance that
Yeah.
you know their rights somehow, because what
Yeah.
they're doing is wrong, you know,
Yeah.
need to be balanced against the rights of the person that they're
Yeah.
doing the wrong to. You know, and that's
Yeah.
where it gets very tricky, because
It does.
unions get involved
Yeah.
and staff are supported
Yeah.
by their union, and then managers are in a position where they can't really act.
And I think that, you know, that's important. You know, I don't think we should ride roughshod over workers' rights, whether those workers don't have a learning disability, have a learning disability, have any. I think, you know, rights are important.
I'm not suggesting that.
No,
I'm just,
no, you're not. Yeah.
I'm just saying that.
And so it is a balanced and measured approach that's needed. There's some really good stuff that's been done in Scotland that I had a look at a few years ago about really balanced, measured approaches to human rights-based support and care that gives some useful frameworks for looking at that sort of stuff. And I guess it's being clear that, you know, we can restrict people's rights. We can deprive people's rights, some rights, not others. But it has to be done in a way that's measured, that's proportionate, and that is absolutely transparent and has all manner of safeguards built into it. And what's concerning is when we start interfering, messing about with people's rights without those protections. That's when it gets really worrying, because you start to shift red lines. I don't know what the term is. You start to move lines that actually shouldn't be moved. And you start to skew then the judgment of people that work in services. What was once acceptable, unacceptable, starts to become maybe it's acceptable. And I think, you know, for me, there's something about having those absolute concrete lines around human, and I think that applies equally to staff. You know, so we can restrict staff's rights, but in ways that are transparent and that are proportionate and that are measured. And where there's a rights challenge. So I think it's about human rights-based approaches are for everyone. Yeah.
Great. Should we just stop there? I'm sure you've got more questions, but I want you now to have an opportunity to think about, you're the experts, what we can do, how can we, or how can you, as learning disability nurses, improve services. So the standards are going to be really helpful. Sorry, you want me to come over here? Okay. The standards are going to be really helpful, I think, and it's a great piece of work, but there must be other things that we can do. So if you think about the whole philosophy behind transforming care, it was basically, I think, three things. It was to improve the health of people with learning disabilities, to improve the quality of their life, and thirdly, to make the services that we provide of a high enough quality that they are meeting people's needs. And obviously, we're failing in some of those areas because we're all here today. So what we've done is prepared three questions. So I'm going to ask you to pair off with somebody. But it would be really good if you work in the community, for example, if you paired off with somebody who worked on an inpatient unit, or if you are working in the university, that you pair off with a clinician. You know, so don't sit next to your mate, if possible. Better to choose somebody that you're going to learn something off, you know, and see things from their perspective, I suppose. So I couldn't get breakout rooms. But we have got a breakout area that, if you go down outside to the corridor, that end of the building, and breakout room, that end of the building. And it also serves coffee as well, so which is a good idea. So if you want to go and find somewhere in your pair, that's good. If you want to stay in here, that's also good. So I would say take about 15, 20 minutes each, and then come back, say at 25 to. Okay, I'm going to... If you give those up. Sorry, I'm going to come up there now. Okay, hang on. There's questions, yeah. Go on. No, not you. Did you ask me something? We're going to come over with you, yeah. Okay. And can I just say, when you come back, if you hand the questions back to... your question sheets back to Rob, while we're having the next session, Rob and Ben will quickly analyse the data to see what the main themes are coming up. God, you're very disruptive. Anyway, there we go.